Yeah, Joshua Schroeder, grant coordinator for Project Aware Lakeland Consortium. This was a grant that brought a lot of funds to those 5 districts. Very rural area, the largest school district area-wise in the state. And with that, being a grant coordinator, I'm not as hands-on, I'm more behind the scenes. I actually work remotely, which I think kind of benefits a lot of things because I can focus on the tasks of making sure that Adam's spending money in the right way without having to yell at him in person. I think that works out well. But no, it's been a great opportunity for me to be able to join him and have him share the excellent work that he's doing. And we also have Christy Johns from Wisconsin Family Ties, a parent-peer specialist, who will also share.
This is one of the biggest barriers to mental health services, and we all see it. And it's not just mental health services, it's healthcare in general. When you first become somebody that's a patient for a clinic, you end up having to sit in that waiting room for about 15, 20 minutes and fill out their chart. Mental health is no different. Some of my providers have packets of 8 pages. Some of them have packets of 40 pages. When we're talking about mental health and we're talking about a family potentially dealing with crisis, we don't want to add to that. We don't want to add to that overwhelm. Let's help them with this paperwork process. So if you're in social services, if you're in the school district, you already know a lot about your families. Take that as an opportunity to say, hey, I'm going to help you in this process because I think that this is really going to help Johnny X. This is really going to help your student get the services that they're looking for. And I can add all the information. I have date of birth, I have address line, I have student's name. Rather than the family having to put that into 14 different forms, I'm getting paid for it. I'd be happy to do that for Johnny and make sure that that process is a little bit faster, a little bit smoother, and it's also going to make sure a little bit easier that that family is going to turn that paperwork around for me because instead of hours worth of paperwork, now they just have minutes. We also do obviously recognize that there's an illiteracy rate for some of our families. Some of those families aren't sure what they're signing. It's really important that we're sitting down with families that want more information, make sure that they're fully informed about what they're consenting to and involving themselves with. Through our school-based model, yes, we're offering services in our school district, but we want to make sure we're upfront that the school district's not paying for the services. They're ran as they would be in a clinic setting, which means we're leveraging the health insurance of that particular family. Unfortunately, some families still are uninsured, and that's an opportunity for us to jump in again and offer resources. So if paperwork is a barrier for some of your families, think about pre-populating as much as you can for them. Walk them through that paperwork. Let them know what they're signing and what it's going to look like. Highlight those additional areas. I mean, that makes it just real easy for mom and dad to say, okay, I got to add stuff here, I got to add here. Whoever the guardian is, they want to be able to do that and do it quickly. So I highlight exactly where they have to add information. Meet them where they're at, too. That's going to be a message that you're going to hear throughout this presentation. Find the space that they're comfortable in. Some of our families, especially up by us, we have families that just don't feel comfortable in the schools. They might feel more comfortable in meeting you at a coffee shop, and we can easily do that. We can also go to the home if that's appropriate. Some families are going to be pretty guarded about going into the home environment, and we respect that. So give them the options and let them really choose what space they want to meet you at. This is also a major barrier for a lot of our service providers. We can get the students enrolled, we can get them referred, but if they're not showing up because mom and dad don't have a way to get them there, or it's a snowy night in Wisconsin, which can happen pretty darn easily, what's going to come off the plate? The counseling session that's an hour and away potentially at travel time, or we can alleviate that by having school-based services. It's a big advantage. I mean, now we're consistently seeing our students on a more regular basis. There's less no-shows. That's mutually beneficial. The school's getting a benefit of it because hopefully we're getting more regulated kids. Kids getting the opportunities to vent out some of those frustrations, to share their experiences, and a healthy environment with licensed professional counselors. The school's also able to leverage some of that information. We don't need to know what's happening in a counseling session. That's not what I want my teachers getting from my providers. What I want them getting is the approaches. Let's reinforce that and be consistent in all environments. One, if counselors teaching Johnny how to use coping skills, what are those coping skills? How are you teaching them that? Because now we want our teachers to say that exact same thing. If something comes escalated up in our classroom, we can reinforce the exact same thing that counselor is saying in session right in our classroom. Hopefully mom and dad, guardians are doing the exact same thing. And that's 3 different environments. Behavior A, Is response B? It's always consistent, and consistency is really effective in these types of approaches. Also leveraging other people. There's always natural supports in everybody's life, we hope. Maybe it's limited, but we have to see who those natural supports are. Sometimes that's going to be our churches, our pastors, our clinicians, whoever those natural supports are, just make sure that they're part of this team. Understanding rights. This is a really difficult area, and this actually is one of the things that I recognize as a crisis screener for our Tri-County. I was doing that for a number of years, and a lot of people don't know what their rights are when it comes to accessing mental health services. So if we have a student in crisis, a lot of people think, well, then we got to call the crisis team. We have to have them assessed in order to get them to a hospital. It's not necessarily the case. We all have rights in terms of accessing medical care, and you can walk into any of your local ERs and request a voluntary behavioral health unit stay, and that hospital becomes required by law to find you that placement. That's knowledge that even professionals I've talked to didn't know about. They've always brought in a screener. They made a choice, okay? It's either going to be an involuntary placement or it's going to be a safety plan. Well, I'd rather a parent and guardian and a student be in power of their own health care. I want them leading that charge, saying, hey, I need this support. I recognize I'm struggling, and I want to access it in my own without my rights being taken away. It's not a small ask when you're asking a county to come in and say, hey, you don't have a choice anymore. This is a crisis situation, and we're going to detain you for safety. And there is this place for that. There are going to be some individuals that are not ready to get their own care, and that's where the county can be leveraged, and an involuntary placement can happen. But we have a lot more successes with those that are seeking care on their own. Go to your local ER, care on your own terms. The hospital becomes required. The one thing is transportation might not be included. So in this situation, this is a real barrier still for our rural community, because some of our BHUs that accept adolescents are several hours away. We're actually very lucky. Right now, we have one that's less than an hour away that just opened up in our area. So that gives our families the opportunity to still care for their student, visit their student during these stressful times, but also that still ends up being a barrier if they have to do their own transportation. Some of our hospitals have really stepped up too, and are allowing ambulance services to help those families get down to the BHU that they might be placed at, which middle of the state. Eau Claire is potentially a possibility. Appleton area, Oshkosh area ends up being a facility that we use often. So Chapter 51s, we also see that there's police involvement. It's not always the best handle with care approach for some of our students. Some of our students, the crisis situation comes out of the home environment, and law enforcement may not be a trusted entity because they dealt with the law enforcement before, and it just wasn't the best relationship there. So we have to recognize that although police have their role in the involuntary placement, it's not always the easiest thing on a student or a person in crisis. The rights being removed. And when we look at BHUs and providing the options for families to access services for BHUs on their own, we avoid the repercussions of losing rights. Now, for our community, we're up in northern Wisconsin. There's a lot of hunting that goes on, and a lot of people that take a lot of pride in being hunters. That means maybe weapons are in the household. Those rights are actually taken away at times, and you have to remove the weapons from the home to keep the environment safe. But that's a big deal for some of our families, especially for mom and dad that live off of the land and are using those resources, those natural resources. Losing their weapon impacts how they put food on their table. So just something to think about. And also avoid the commitment and settlement agreements. I'm not sure how many of you are familiar with that, but whenever the county detains somebody, there's usually some kind of follow-up order that happens. And that's either a settlement agreement or a commitment order. There are two levels. The commitment order is the higher level. The settlement agreement is the lower level. The settlement agreement can range from 30 to 60 days. It's basically a check-in from the county saying, hey, we paid for your services going to that hospital as a county. Are you getting the follow-up services that were recommended after that behavioral health unit stay? Some families say, yes, we're getting the services, we're doing good. Some families say, nope, haven't done a thing. And that's why those are in place, to kind of follow up with those families. However, the reality is, the only repercussion of not following through with services is a rehospitalization. As a screener myself, doing these settlement agreements and the commitment orders, following those individuals, wasn't about to punish a student for mom and dad not completing the paperwork on a referral and sending them back to a hospital when there wasn't a crisis situation re-emerging. It's just not fair. It's not something that's beneficial. I see a hand up. Mm-hmm. Yeah. Not legally. Legally, your ER is required to find you that placement. That hospital staff, and I have many hospitals doing this for us, is required to find that placement for them. So they actually become legally responsible for that individual's care through the ER. Go ahead. Exactly that terminology, and I really encourage people to listen to that. I'm looking for a voluntary behavioral health unit stay, because what ends up happening is a lot of the time the ER is not familiar with that, and they don't know that that's the requirement by law for care. So if you use that exact terminology, that we shouldn't be doing that for you. I'll be honest, and that's something that we've seen, and that's why I need people to know that their rights are being violated when that situation happens. That ER is required to find the placement. Now, not every hospital has a BHU, so it's not like I can go to Howard Young in my area and say, this is an adolescent, they want voluntary care, put them in your hospital. No, then Howard Young becomes responsible then to outsource that to BHUs that accept adolescents. What my experience is 3 strikes. Basically, they call 3 different hospitals. If 3 different hospitals cannot accept that individual, then the state facility becomes required for it, and that's when you can leverage Winnebago Mental Health Institute, which we'll talk about a little bit more. Winnebago is only available to those in an involuntary situation, though. So what happens is a lot of the hospital staff will actually say, nope, we're calling a crisis screener. That's actually not allowed. They're not allowed to call a crisis screener for somebody that's trying to seek voluntary care. I see another, yeah, go ahead. Yep. Yep. That's a great question. It is because we have to make sure it's not a medical concern. We have to make sure that there's not underlying issues that are leading to the mental health situation that that person's in. It's also for clearance. So when you are calling those hospitals, and I'm going to use my hospitals for example, I'd be calling St. Elizabeth's, I'd be calling North Central Healthcare, and I'd be calling Willow Creek. Those are our 3 closest adolescent facilities. Now they're going to want to see those labs before they say, yes, we'll accept this individual. So they have to make sure that this isn't a medical concern, that they're not taking a patient in that really needs different types of services at that time because of other medical conditions. So that's why they do those testings. Really appreciate those questions. And if you want more information, I'm going to be sharing my contact information at the end. So we'll keep moving on. Less county involvement, more control of your own care. That's the real core of this, is let's put these families in power. Let's let them know that they have resources that they get to leverage on their own terms for their student or for themselves. This is a really important piece to any type of care, is collaboration. We're all talking and using the terms cross-system collaboration, but how many of us are effectively doing it? Few. But we can improve on that by getting a release of information. This should almost always be the starting point of any relationship when we're talking about mental health. For me, if I'm referring a student to a mental health provider, the first form they're signing is a release of information between the school and that provider. That gives me the right to coordinate the care, to help with the referral process, but also to collaborate with those individuals that are serving the student. Obviously, that takes time. I don't expect my providers to meet a student and say, hey, this is what Johnny's going to need to be successful in your school. I realize there's a relationship that has to be built, but after time, when that relationship is built, you bet I'm going to be coming to you and saying, hey, Johnny's struggling in our building. What can we do better? Question? Great. Yep. Yep. Sure is. Yep. What I'd say is I leverage Indian child welfare in our communities too. One of our schools is the Lac du Flambeau School District. It is a public school, but it's something that we see regularly. And we leverage all of those social services. ICW is not in a solely situation. This is not a Native American exclusive issue. I'll leverage social services in this way for any of our students. And we need to know who is the legal guardian in the court size, because they're the only ones that can consent to care. If it is through ICW, if it is through social services, they're the ones that are seeing my referral packets, and I do this often. That's a really hard job. We need to support our social services. We need to support our Indian child welfare to get these students into care if it's appropriate and if the student's willing to do it. This is just one way that we can create partnerships with those agencies by supporting them through supporting our students. Again, it comes back to a release of information for that too. I want that release of information with ICW, with social services right off the bat, so I'm doing this the right way, that I can coordinate the care in the right way. We can collaborate when it's appropriate. Better understanding of the whole individual. This is really important for me too. So if I have a student in the hospital and I know that there's going to be some recommendations, what are those recommendations? Now with that release of information, I can get the discharge summary that says, hey, counseling is recommended, medication management is recommended. Now I can call that family, that guardian, that ICW worker, that social services guardian and say, hey, this is what was recommended. Through the school-based model, I can access care this way, this way, this way. These are your options. Let me know which one you want to go with, if you want to go with any at all. And if it's a no, it's okay. We're still here, and we will continue to be here as long as you're students in our school district. Better communication, less chance of inaccurate reporting. This is also something that I think is going to answer a little bit of your question, is if ICW is involved, social services is involved, I want them talking to the providers at these hospitals directly, because they're going to know the background information that I might not be privy to, but it's also accurate reporting. If we are going to this point where a student needs care in this way, it may be deriving out of a home environment issue, that mom and dad are very, very concerned with that getting out and being guarded. They're not going to share that with the provider, but that's really important information for somebody that's prescribing meds to know the well-rounded individual. And that's where having my school staff provide some information as to what they're seeing in their classrooms on a 40-hour-a-week basis. They're seeing these students. That might be more time than mom and dad are getting with the student at that time. And they could be really accurate reporters to give that provider that well-rounded view so that they're doing their job with confidence. This is a big part too, as we're all seeing there's a lot of stress in these works. There's a lot of burnout. And we need to support our staff as much as we're supporting our students and individuals. And that's by giving them resources. I do not want my English teacher that's not very comfortable with the conversation of suicide or mental health being that point person. If they're not ready for that, that's okay. But make sure they're getting them to somebody that is comfortable with having that tough conversation with the student so that we can leverage supports. That hopefully takes something off their plate. Because one of the things that concerns me most is when we have professionals like yourselves or school staff members that are going home with this huge weight on their shoulders. Did I do the right thing? Is Johnny going to be okay tonight? Because then they're going home and they're not getting the best restful sleep that they need. They're stressed out about it. They're not sure if they're doing their job great. This is one way to take that weight off their shoulders and outsource it with real professionals, licensed professionals that are ready to do that kind of work for us. Okay, so this is kind of a segue, but a really important topic that I want you guys to know about, because this is happening in your state, and this is happening with your state's behavioral health unit. This is our school collaboration with Winnebago Mental Health Institute. Now, Winnebago is our state facility. It's the last option for an individual that cannot find placement with another BHU. They end up at Winnebago. Winnebago cannot say no, which means that Winnebago is really busy. We need to support them, support us, and support our students by collaborating for those exact reasons. So I'd like to give some shout outs. One, to Winnebago for being willing to do this. to the Lakeland Consortium schools, which was a leader in getting this started. This is one area as a crisis coordinator that I was like, this is a huge gap. This is an area where we're sending these students away for 3-4 days. They're coming back to the exact same situation that led them to the crisis to begin with. What can we do better? How can we get more information to those families, to our support staffs, and get them the resources that are being recommended? Chippewa Falls Area Unified School District's also an AWARE grantee right now in their 5th year. They're also a huge part of this pilot program. I'd like to thank the Office of Children's Mental Health. That is our direct report to the governor about this issue. Department of Health Services and the Department of Public Instructions. Okay, so this work grew out organically, basically out of the Project Aware grant and my recognition and our group's recognition of gaps that we can easily close just by having this collaboration opportunity. So what we do is on a monthly basis, we meet with the leads from Winnebago Mental Health Institute and we talk about what's working, why is this beneficial, what is not working, what needs to be improved, and we share data. What we're finding is, through our data-driven reflections, is we're seeing an improved care, better systems, continuity of care, and coordinations of services. We discuss the roles and responsibilities of what we're doing in the school districts versus what Winnebago can do for us. We're really emphasizing the communication and collaboration. We're using proactive approaches rather than reactive. If we can get ahead of some of these crisis situations, hopefully we're not seeing that revolving door of student X coming back to us 2 weeks later, they're back in the hospital struggling with the same issue. If we can get ahead of it and get those proactive approaches in place, hopefully we can keep that from happening. Recidivism is part of the state's mental health goal to see a reduction in that. This is helping. It's not easy, and it's not always perfect. But I see some heads nodding that people are experiencing this as well. Expanding the collaboration. Well, it's really about the entire state that leveraging this. This is a pilot program that's just being started, but it's something that Winnebago is ready to do for the entire state. What we need is the boots on the ground. We need staff like you to say, hey, I know that this is happening. We're in the middle of a crisis, mom, dad. When you get to the point of intake, make sure you're signing a release of information for social services, for the school district. Sign all these releases so that we can all work together to support your student. My experience is families don't turn that down, especially in crisis. I rarely have a family that's saying, hey, no, not signing that. They just want the support to make sure that their student's going to be the most successful that they can be in our districts, in our communities, and in life. They want us to leverage these individuals and give the best information to them so that we can support them to be well-rounded individuals. Okay, so what is the benefits? What's really the meat and potatoes of this pilot program? What are we getting out of it? Well, you're going to see 3 tiers of benefits. One for the counties, one for our professionals, one for our students and families. And I start with the students and families because that's the most important to me. Follow through with the discharge plans. Families that are going through crisis, their world is spinning. They're coming out of it. They don't know how Johnny's going to be when he gets home. They're scared. They're concerned. They want help. Now we're able to follow that discharge plan, and they're going to get a follow-up call from Mr. Nowak after a crisis situation saying, hey, I got the discharge plan. Sounds like counseling might be appropriate for your student. What do you think about that? Well, I don't know. Okay, well, let's talk about it. What are your concerns? What are your thoughts? I try and explain those services, and I offer options. One, we can do telehealth. Sure, that's great. Well, we can do that in the school. Sure, that's great. Well, my students really academically focused, and they don't want their school day interrupted. They don't want anybody in the school district knowing about this. I get that, and I understand that, and I respect that. That is wonderful. Can I help you make a connection in the community then? Sure, that'll work. And that's just an option that's available. It doesn't have to be a school-based model. What I want to see is a student that wants services, that's trying to access the services, is getting it in the way that they want it. Whether that's through the school because it's more convenient, wonderful. If it's in the community because they're more comfortable with it, yeah, let's do it. Sign them up. Help the family through that referral process. Make sure they understand what's been recommended. They're getting so much information, so much paperwork, and if you've seen a full discharge plan from a BHU, boy, you got some reading ahead of you. And that's a thick packet, and for a family to navigate, where is the important information here? What's my next steps? Even finding that can be difficult in that thick packet. That's where we can step in and help. We're also seeing shorter wait times. Because we have these partnerships, We have providers that are exclusively working with these adolescents, and they're willing to take these referrals, which means shorter wait times. Our biggest entities right now are about 6 to 8 months for counseling services on wait lists. We're 2 to 3 weeks. Pretty proud of that, and that really has to go back to my school districts to say, hey, they're the champions that brought this about, and now we're able to get our students better services quicker. The last thing you want to do is say, hey, I'm sorry you went through a crisis, but 6 to 8 months, we're going to get you the support you need. That's a long time to wait. 2 to 3 weeks is a long time to wait when you're in crisis, but it's better, and it's a work in progress. Other things is that consistency, that real-time communication, collaboration. These things are stressful, and there's a lot of triggers that happen when we're going through a crisis situation. Let's not force the family to revisit 16 times and talk to 16 different agencies about what that looked like and how stressful it was, because it's just revisiting that trauma. We can help. It also just creates that consistency with approaches. The 3 environments that I'm talking about, that's just the beginning. That can be expanded so many different ways, and you have to be creative with that. Maybe there is a church that's a big support for this family. Maybe they benefit from knowing what some of those approaches are. But it, again, comes back to getting them a release of information. This is also a big part of our school-based model. We have school nurses in most of our buildings. Some of these medications can be pretty dangerous, and we want to make sure they're being taken correctly on time as best as we can, but that they're not just floating around in our school buildings because Johnny's got them in his backpack, he takes them at noon, and all of a sudden he forgot that he set the pill bottle down in the bathroom and another student comes across it. That's something we don't want. So having our school nurses involved in this collaboration can be really, really responsible, but also really effective for families that need some help with making sure that medications are taken consistently, but also that they're secured when they're in our school districts, because some of them are. It also helps us to recognize side effects, which is really important to me because for me it's about care. If Johnny's having a medication change and all of a sudden drowsiness is one of the side effects of that new medication and we can't keep him awake in class, he just keeps putting his head down, the last thing I want is my English teacher sending that student to the office punishing them because they won't stay awake. We have to handle with care, and if our staff have that knowledge, we can let our other staff know, hey, thanks for letting me know about this concern, but we also need to let you know there's some new medications. You don't need the details of it, but some of the side effects might be showing up in your classroom. So just give them some space. Hopefully, we can also talk to the provider and say, hey, this is really impacting his day. He can't stay awake. We might want to take a look at whether or not that's an appropriate medication in terms of the amounts and let the doctors decide from there. If the doctor doesn't hear that from us, he may not ever have that knowledge, and then they're not adjusting things. And then the family says, nope, I'm just going to end up not giving him the meds anymore because school keeps calling me every day saying Johnny's sleeping. Just one way to kind of work that around, giving options to families but also supporting our providers. So what does our school and our teachers really get out of it? We've already kind of talked on this, and I'm going to move through these ones a little bit quicker. But it's those best approaches. Lets us know that medications might be changing or are being implemented for the first time. It gives us that opportunity to handle with care, to say, hey, we know you were gone. What can we do to make you successful this week? What do you need? Do you need space? Do you need breaks? Can we offer that? Can you utilize student services in our calming rooms if you need to? And that can just be, student gives teacher X a look. Yeah, go ahead. Take that space you need. Come back when you're ready. And it improves the student-teacher relationship, which is absolutely key. We're asking our teachers to do a ton nowadays, and I think probably everybody in this room recognizes that we're not asking them just to teach academics. We're asking them to be caregivers. And this is one way that we can build that relationship by giving them some more information that can help them support that student going through this. This is exactly what I kind of talked about in this slide. I want our staff feeling very confident that they're doing what's right for the student. And if they can be that person because they have the relationship, wonderful. But if they're not comfortable with it, the most important thing is that they have tools in their tool belt to leverage. That they can call up Mr. Nowak, they can call up student services and say, hey, Johnny's off. I don't know what to do with it. He mentioned suicide in my classroom, and I'm really scared for his well-being. Teacher X, thank you for calling me. I will be pulling him down right now and having that hard conversation about suicide, and I'll be pretty direct with them in those conversations to make sure that their safety is taken, most importantly, number one. Students' academics, in my opinion, come secondary. Not all school staff look at that way. They're there for teaching for some of them, and that is true. That is our core responsibility in a school, but we can also do that with care. Providing those strategies and approaches to a teacher identified by our mental health professionals can give that staff those effective tools and make them comfortable with an uncomfortable situation. What is the true goals? Is the staff morale is improved. Staff satisfaction's improved. Hopefully we're losing less teachers, less professionals. Okay, what do the hospitals get out of it? Well, a hospital is making these determinations, these recommendations for a reason. They think they're the best ways to help the student be supported. And they don't want to see that student again, not because they didn't like the student, but because they have a large job. And it's really hard for the same student to come through 4 different times and them to feel satisfaction that they're doing something right when nothing really is changing on the back end. We can help shore that up by offering some of these things to our families. We also can leverage some of those major supports that all of our counties have, that comprehensive community services, the CLTS program, the Children's Long-Term Supports, the CST, the Coordinated Services Team. Those are all wraparounds that many of your counties are going to have that are available to these students for mental health concerns. We just have to give them that access point, help them through that referral process, which is time-consuming. But it's also supports that families don't know that they can leverage at times. Talking about the school staff, giving an accurate report to these providers without that vested interest, without that guardedness that some caregivers are going to have because they're worried about their home situation. They don't want to lose their kids, but they also want to protect their information. Decreasing the recidivism, resulting in decreased caseloads for the behavioral health units in general. Again, better staff morale for our hospital staff, better work satisfaction. Feeling those successes is important to everybody in their job. Less turnover. Now, what do the counties get out of this? If we're doing this and the counties see a benefit, what is it? Well, it's decreased expenditures. Counties that chapter individuals pay for those individuals' stays. It's about, if I'm not mistaken, about $1,200 per night, per student at Winnebago Mental Health Facility. And they're generally there for at least 3 days, generally. 72-hour hold is what they're typically signed up for. $3,600 right out of your county's pocket for that. I'd like to see that money used proactively because this is a reactive approach. It increases that opportunity for that. It also gives an opportunity to successfully reintegrate discharged community members with the proper support services being leveraged in a more effective, proactive, and timely manner. That's the end goal for everybody in this field. We want to help people, right? I doubt many of you got into this field to make millions of dollars and live the good life. You probably got into it because you care and you want to be those people. This hopefully is giving you that opportunity to think about this in just a little different way and leverage some resources for yourself, for your students, for your community members, for your hospital staff too. Okay, less personnel being pulled from local communities. For our community, as an example, our law enforcement actually do the transportation for Chapter 51s. So we are handcuffing our students, our community members, when they're detained on a 51 and putting them in the back of a squad car to travel them several hours away to an unfamiliar community, putting them in a BHU. I'd rather see our law enforcement in our communities, serving our communities that they're assigned to. Appleton area, Winnebago specifically, about 3 hours away from our community. That's one way. So that's a full day for that officer. The cost of the crisis screening situation is a real problem too. Families are getting charged for these services in a lot of communities. So if you have health insurance, hopefully it's leveraged. But for those individuals that are in crisis that don't have health insurance, they could potentially see a bill. Now our agency is actually moving away from that and recognizing and asking those questions a little bit more transparently in the conversation right up front. The last thing you want to do is insult somebody and have another crisis situation come up because there's a bill that's showing up at this family's door after a really stressful situation. Again, increasing the knowledge on voluntary options for services. That's the best thing, is when a family says, hey, we're in control of this, we're gonna make this decision for our student, for myself, or my individual, and they access the care in their way that they want to. And less removal of rights. I already mentioned it, removing the weapons is a responsibility for somebody that goes through a BHU stay on an involuntary, and it's stressful. But those families have those weapons for a variety of reasons, whether it's safety, whether it's hunting, whether it's other reasons. They have them for a reason, and they don't want those rights taken away for our community members. You might see that as well. It also means less subsequent orders, less following from the county, less opportunity for somebody to say, hey, what are you doing? Are you doing it the way you're supposed to? And if not, punishing them. I don't particularly agree with that. So what are we hoping to get out of this Winnebago pilot? What are the anticipated and preliminary outcomes? Well, it's hopefully less involuntary hospitalizations. It's fewer expenditures from our counties, which means more available funding for mental health services in a proactive manner. Options available for follow-up services in a variety of different ways. There's improved staff satisfaction all across all settings. Everybody wants to be successful in their work and know that they're doing what's right for their community members. And then going back to the core, the cross-system collaborations and communications is better. That is in our state DPI's statewide mental health plan, is improving that collaboration. This is one opportunity for you guys to think about as you're navigating your own mental health services for your students, your social service caseload, for whatever type of work you're doing. These are just conversations that you can be the starting point for. Making these recommendations to a family that's seeking care. Talking about releases of information and what they can allow. Now, I do want to talk a little bit about releases of information. I'm trying to be mindful of my time. Try and get you guys on the road a little early if possible. The releases of information that I use are very broad. I mark a lot of the boxes and I pre-populate a lot of them. And I put them in front of the families and I say verbatim, this is your release of information. Look at this. You're going to see that AODA is checkmarked. Adam, my student's a third grader. There's no AODA concerns. Yeah, that's true. But I also have high school students that do have some AODA concerns, so I use that same form for them. And that might apply to them, but not your student. If you're not comfortable with that being marked, I get it. And I'll give you a complete blank copy. We'll populate it together. You can check which boxes you want. But I'm going to ask for the world. Doesn't mean I'm going to use the world. It doesn't mean that I'm going to have these detailed conversations about what this release is allowing, but I don't know what the needs are completely. And we may find that this is something that's going to come up, and we can help you with that situation. So keeping it really broad is important, but more important is that you're informing your families about what they're offering and what these releases are allowing for, making sure that they are comfortable with it. The last thing you want, and I've seen it, is I didn't know I signed that release allowing for that. Don't burn those bridges. Be respectful of the family's rights, what a provider cannot share, and stay to what's going to be beneficial for the student. If you're doing it for the benefit of the student, there's value there. If you're doing it because you want some information about what's going on in the home, make sure you're being recognizing that. It's not always the best way to use these releases. Even though the family trusted you to sign them at that time, keep that trust. Talk about it. Make sure that they know what they're consenting to. The end goal is that increased mental health and wellness for our students and families and community members. So, this is just one way that we can navigate the mental health field. But there's a variety of different ways, and you guys are all doing it in your own way. Continue to do that. Think outside the box and ways that we can leverage the communication collaborations and rebuild relationships. One of the things that we're very recognizing in our Lakeland Consortium is not every student's family has had the best relationship with the school districts to begin with. Their experience kind of dictates and rolls over to that next generation. What mom and dad says to their student about their experience in school impacts how their student views school. And we can rebuild some of those relationships by leveraging some of these things in the right way. And that's where I'm going to kind of turn it over to somebody that I think is really helpful to our consortium schools, and that's Christy Johns. She's a parent-peer specialist through Wisconsin Family Ties. And when we recognize that this is a family that just doesn't have the best relationship with the school, we try and implement her for a variety of reasons. One, she can be that conduit. We all have to recognize that we're not perfect, and school districts make mistakes too. And that's where she can kind of jump in and say, hey, school, you're doing this. That's not the right way to do this. She's got an intimate knowledge of IEPs. She can help to make sure that schools aren't railroading a student, but also that families are recognizing that schools have a responsibility to give them an education and to do it the way the state standards dictate. So I'd like to just have her talk for a few minutes about some of the ways that she leverages family relationships in our consortium to rebuild some of those communications to, in the end, support our students.
Thanks, Adam.
Yeah, I don't think so.
Hello, I'm Christy Johns. I work with Wisconsin Family Ties. That was a great intro, Adam. Thanks. So pretty much the goal of my job is to impact a family in a way that helps them best support their student. And that can look so many different ways. It's not only the school system. It's getting them in contact with county resources and helping them in practical ways. I had a family who was tremendously stressed out because they needed to get this pre-authorization from their health insurance. However, they work and they don't have 4 hours to sit on hold with their health insurance company. So I actually sat on hold with their health insurance company for several hours, and then I merged that call as soon as somebody answered the phone. I've had families who couldn't figure out how to call somebody to come out to help change locks at their house. I got them a list. We have the Warming Hearts Fund through Wisconsin Family Ties, and we managed to get that covered for them. I help them with benefits, getting in contact with churches. Sometimes the schools don't understand that if families can't figure out how to put dinner on the table, we're certainly not thinking about how to get those mental health needs met because there are more important things in those moments. So there's a lot that we can do to help, and I like to get everyone on the same page and get those service systems to communicate. I want the school to know who the CLTS worker is. I want the CLTS worker to know who the case manager is. I want the case manager to have an understanding of where these families need support, because sometimes families don't even realize where that support is needed. They might be thinking, oh, well, my student needs help with XYZ, and then you talk to the student, and it's a completely different story. So getting everyone on the same page and being able to support the whole family unit. Does anybody have any questions? No? Wow, Adam must have given you a lot of information. Josh, do you want to talk about your job?
My job is just numbers and reservations.
What I'll mention is we're really lucky to have the grant that we have, and that's part of why we're able to put Christy in the role that we have. But a lot of your counties probably have a parent-peer specialist through their CLTS program, through their CCS. Not every county does, but some do. So just another resource for you to tap into. This is really a role for parent support, but sometimes it's about supporting the student so the parent feels supported too. Just making sure that you're recognizing that there are different opportunities and different needs for each individual family. See a question?
Does your county integrate CST into
Love that question, and that's something that I'm very, very on board for. What I'll say is I had a background as an ESP crisis screener, but I also was part of the CCS program. That was just a natural environment for me to leverage. If I have a family that is in need, I want to see that student in the school, and I want to create that relationship with the school because they're a big support for that individual. Certainly, I do want to go to the home too, but I want that CST person in our district. And I actually have created those partnerships. They're county programs. So if the family is okay with signing a release of information between the CST worker, the mentor, and the school, yes, leverage us. We'll give you the space to do your CST work right in the school building. Why does that work? Because mom and dad don't necessarily want somebody in their home at 3 to 5 when they're trying to get their dinner on the table and they have a visitor coming in and all of a sudden it's throwing a wrench in their plans. Now we're doing those services right there in the school day. It's happening during a convenient time. Mom and dad don't have to worry about transportation to the office for those workers. The team is aware of it. The school now knows, hey, this is another person I can leverage to get to know my student a little bit faster, a little bit easier, and use some similar approaches. So CST CCS is a treatment plan. What the heck are you working on in that treatment plan? Because I'd sure like to know. One of it might be school related. And if I'm a teacher that now knows that one of the goals on that CST plan, that CCS plan, is related to the goal of schoolwork, boy, I'm going to leverage them. I'm going to make sure that CST person now has the packet that I'm sending home with the students so that they can work on that in their session. Now, that packet's getting turned in. I've never had a packet turned in from this student because I send it home with the student and nobody's following through with it. If I have county level workers, they're likely going to help us follow through with that request. And it creates a relationship too. Now I recognize a need for a student and I know exactly who I go to. I know who in the county I'm calling for that because they're showing up in our buildings on a regular basis. That is something I highly encourage. Our county right now is ran as a tri-county model. It looks like that's going to change. And my push, if the counties are going to take on those roles, is to have that person directly in the school district on a regular basis. Their office should be in the school, especially if they're working with adolescents. It just makes natural sense. It makes a convenient, accessible place for them to do their work, helps us to be able to identify and refer students to them faster, gives them that natural connection to the students. So that to me is something that if your county's not doing it, I'd be pitching it to those CST workers. I'd be going to those coalition meetings and saying, hey, how often are your staff members going into the school? And would you be willing to do that for us? It doesn't have to be always, because some of those services aren't appropriate for the school, but some of them aren't. A lot of them end up being related to some of the things that the schools are seeing. It also helps in that process of creating the treatment. Again, our school staff can be those reporters saying, hey, these are Johnny's strengths. He's awesome at this. But these are also his areas of need. And then that worker can say, hey, we can incorporate that into the next treatment plan, or we're ready to move past this goal area, and now we can start this new goal area. Thanks for that information, that collaboration. It all goes back to the release of information. That's your starting point. But also families love it. They really like the idea of one less thing on my plate. Snowy conditions are right upon us in Wisconsin here, guys. Transportation is going to be a barrier. Getting to and from these appointments, making it more convenient makes it more consistent and effective. Thank you for that question. I think that's a wonderful one. Seeing we're about 20 minutes out. I'm not going to keep you here if we don't have more questions, but I'd love to answer questions or just get some feedback from your own experiences, things that you've navigated in a unique way that you think is beneficial to this group. That's probably why you signed up for it, so feel free to take this opportunity to share your experiences if you'd like. Go ahead. Yes. Yes, I do. Yes, based on caseload. Basically, we make that MOU with these providers, and that's going to be your starting point. Memorandum of Understanding is just a fancy way of saying we have a contract, and all it's saying is this is your role responsibility, this is our role responsibility. What our role responsibility in the school district is usually about three things. One, HIPAA compliant space, access to students, and we help coordinate the services. That's my role on a regular basis. And what I try and do when I talk about coordination of services is I say, hey, provider, what day can you be here? What times do you have available? Okay, does it match up with my counseling space, my HIPAA compliant rooms availability? Book it, but also check the school. Like, is this a math class that Johnny's falling behind in? I don't necessarily want that as a session time if I can avoid it. Can I find an elective that the student's doing really well in or isn't going to affect their academics to a detrimental amount? It's not always perfect that way. And what I will say is if we're having a high-need student with mental health concerns, that's got to come first. Math is important to me. I'm not a strong math person, but their mental wellness is more important because that's going to keep them alive so that we can eventually start shoring up that academic place when that student's ready through this process. Other questions? Thank you for that one and that input. Yes, on a daily basis, all 5 of our schools have regular counselors based on need. Yep. Telehealth is something I'd always often recommend too. We were in a unique situation a couple years ago. We started this grant with the idea that telehealth was going to be something that we wanted to see in our rural community. Part of the reason that we got this grant is we're known as a mental health deficient area. I believe we're per, I'm not even going to quote that. I'm not going to get that data correct. But it's a deficient area, so we don't have the providers. So what we wanted to do was, where are the providers? Well, a lot of them are going to be in the urban communities, the Madison, the Milwaukee areas. If we can use telehealth, we can get services up in this community using internet-based services. And we thought that was going to take a long time. It was going to be a lot of red tape for the state to allow for that. And although there weren't a lot of silver linings to COVID, that is one of them. And if you're not leveraging it and you're in a rural community that has not enough providers to meet your needs, talking to some of those bigger agencies that are actively accepting referrals in the more urban areas is a great opportunity to leverage new supports in a different way. And our students, my high school students verbatim will say to me, I just love that I'm not going to run into them at Walmart. I'm not going to have that awkward situation when I'm serving tables that they're going to walk in and they know my details. It just gives them that space to be authentic. And it just gives options too. Great thing about telehealth is school shuts down one day because it's a snow day. Telehealth is still available as long as you have internet at home. You can do it from the comfort of your own home. Summer transition, that's always a hard one for us. We're losing students during the summertime to these services because they're school-based. Telehealth gives us the option of continuing those services through those summer months, which is really important for consistency and effectiveness. See that hand up again, go ahead.
My daughter uses telehealth, and I just want everybody to know that it has made a world of difference because when she finds a provider, that provider knows what medications work and that's a big problem with mental health. And she's able to, and when she's working, she's able to use that time to tell them that she needs to use her laptop and go. So it makes a world of difference to a student to see that provider.
Yep. We're also keeping our students in the buildings a lot more. Through the school-based model, instead of our students having to be pulled for half of a day of school because they have to travel to their appointment, it's 1 hour. We can get them in and get them out. They're right back into the school. They're right back into their classrooms right after that appointment and not traveling that hour and a half distance one way. Yep, thank you. I got it. Thank you. I guess I wanted to add one other piece to that too, is when you're looking at telehealth, it's just a different way of looking at it, and it just opens up an opportunity to do this in just a more effective way with less time constraints, as you had mentioned. So thank you for sharing your, go ahead. Yep, thank you. Year 5, the AWARE grant is a 5-year grant. It's not re-upped, and we do not expect to get the funding from the DPI and DHS and SAMHSA again. So what we're doing is we're showing the worth, that we have hundreds of students using this service, that we have staff members that champion this type of work because it's taking something off our plates, specifically our school counselors. Our school counselors were inundated with the mental health needs of these students at times, and it becomes really overwhelming and really time-consuming. If we can outsource some of this, they become our biggest champions because now they have more time to focus on other parts of their job. School counselors do have a mental health role, but it's not an exclusive role. That's not their only purpose. They're also supposed to be helping with academics. They're supposed to be helping with scheduling. They're supposed to be helping with future plans, whether that's vocational work or college. All those things fall under a school counselor's plates, which people hear the term counselors. Many families think, oh, they're doing counseling with a school counselor. Not necessarily the case. We can take that weight off of them, give them more time by outsourcing it a little bit, and that creates that sustainability. So what we're asking our school districts in this last year is to start thinking about what it's going to take to continue this process. Because of the MOUs and the way we create that's design, the services are easy to continue. We're not paying these providers anything from the school district. They're doing their work just as they would be in a clinic setting. We just have to have somebody that coordinates these processes, helps it with the referral, and that's where my role comes in as a navigator. So we're asking our 5 districts to divvy up my salary along with our parent-peer specialist salary and continue that work by using new funding that's available through the ESSER funds. If your school districts are, if you're part of the school district, you likely have some of those. Those are things that you can leverage. Unfortunately, our governor's biannual budget a lot of cuts happen to mental health services in our schools, so that's not a huge leverage point, but there are some school districts that got more money this year, and that money can be utilized to maintain roles like a navigator. But really the meat and potatoes of this, the important part is the services, and if you're not paying for the services, there's absolutely no reason they should ever stop. As long as families are accessing it, they're finding convenient, you have providers willing to do it, continue that work, and that's really the sustainability piece, is just continuing those services in our building. And if the districts decide to keep my role, I'm certainly going to be very excited about that, but I'm also going to recognize that what we designed in year 1 was meant to be ending at year 5, but that doesn't mean the services can't sustain, and we will sustain them, because we have partners that want to do this work and have been successful in doing this work. Great question. Did it answer everything that you were looking for? Good. Wonderful. Okay, guys, 15 minutes early. Any other questions? Thanks for being here. Thanks for being you.